Welcome back to Design to Thrive. We have a guest all the way from Florida. He's in the mental health, addiction, and intervention space. Welcome, John.
Thanks for having me.
You're welcome. Let's begin. So, first question, what inspired you to establish full life comprehensive care?
I'd worked in the addiction and mental health space for, I would say, close to 10 years. Everything from working in a crisis stabilization unit where people are hospitalized involuntarily to working in a larger dual diagnosis addiction treatment and mental health facility. And basically, what inspired me to create Full Life was I noticed a very clear gap in care, and specifically for people that were cycling in and out of addiction and mental health facilities. There seemed to be a lot of emphasis placed on the inpatient portion and not a ton on like support services and aftercare planning. And that's where I saw like kind of a big systemic failure.
Okay. Yeah, I mean, the mental health space is a tricky one, right?
Oh yeah. Yeah, to say the least.
Lots
Yeah.
of different characters in there.
Yes. Lots of characters for sure.
So, how does full life differ from traditional case management services?
Sure. So the model we use is called assertive community treatment. And the whole idea behind it is it removes the conventional barriers to treatment. And what I mean by that is that when you step down from an inpatient facility, the expectation is that you go to whatever outpatient programming there is, whether it's a psychiatrist, individual therapy, group therapy, you have to show up for set appointment times in a facility, right? And theoretically, that sounds fine for people that are higher functioning and motivated, they'll show up to their appointments. But what we know in the mental health space is people have varying levels of motivation, varying levels of, functionality. And so that doesn't work for a lot of folks, not because they don't want to, right? Or they don't need to, but truly because they don't have the skill set often, or maybe some of the internal motivation to do it. And so how it differs is that, with a community based model is we go to them, right? So our case managers are boots on the ground in the community. We do like in-home based care. We'll transport them to appointments, manage medication, assist with vocational assistance, job placement, helping them develop support systems. And what's cool is that we can get really creative and we don't have to exist within the traditional barriers of treatment. And we can talk to people after hours. We can work with people on weekends. Mental health doesn't just exist in a clean 9 to 5 setting.
That's right. Yeah, mental health is all day, every day.
Yep, exactly.
So, can you provide an overview of the key services you offer, like case management, recovery coaching, or safe transport?
Sure, absolutely. So I'll start from kind of like the most intense down. So we do a lot of crisis intervention work, and that's both intervention and crisis intervention work for people with primary and severe mental health issues. So psychotic disorders like schizophrenia, schizoaffective disorder, bipolar 1. Okay, it's kind of a subcategory of serious or severe mental illness is what it's called. And we'll do in-home crisis intervention, all done by licensed clinicians. So there's a lot of folks that do intervention work and they're not licensed, which is fine. But when it comes to the severe mental health, it's important that you have a clinician do it. And then we also do traditional substance use disorder interventions as well. And we can do that nationally. And then we do a lot of consulting for families. And the reason we do that is that I find a lot of families call and they say, we need an intervention, we need an intervention. And really what they need is some direction. If you're trying to find help for a loved one, it is incredibly daunting. You turn to Google, you don't know what you're reading, you don't know if what you're seeing on the websites are accurate. And so what we do with families is we assess the needs, we can do an assessment, and we find appropriate treatment placement, and then we coordinate the care with the individual while they're in treatment. And then as far as the safe transport is concerned, it's exactly what it sounds like. Again, for somebody that is motivated and higher functioning, they'll get themselves to treatment. That's fine. They don't need us. But then some people just, if they, for example, if they go to a primary addiction facility and then it ends up being that it's more of a mental health problem and they get hospitalized, we can pick them up from the hospital and travel with them, fly with them, and go with them to the next level of care and make sure they get, handed off to the next treatment provider. So it's basically just like a companion to go with them to make sure they get to where they need to be. The case management services I went over, recovery coaching is kind of a extension of the case management, and that if we have clients that have substance use issues, then we implement the recovery coaching, relapse prevention, getting them plugged in with support groups, drug testing and monitoring when needed. And so yeah, that's basically how we do that. And the last part is that we also have a full clinical team, so they can do outpatient therapy.
Yeah, about your clinical team. So you have psychotherapists, addiction professionals. How does that enhance the quality of the care?
Well, so in terms of setting up a robust aftercare plan, you want to, like, the clinical component is very important for people to have counseling, therapy, guidance, working through mental health issues like depression, anxiety, using cognitive behavioral therapy. And then they work in tandem with the case managers or recovery coaches so that it's a very collaborative approach. And so what we found is that and I can speak to the limitations as a therapist, right? I have, private practice caseload, and I know that at the end of the day, the person's coming in my office for an hour or whatever it may be. I got no idea really what's going outside. All right. I have no idea what happens when they leave my office, when they come back. I hope they're telling me what's going on. I hope they're being forthcoming. I hope they have the insight to know what they need to work on. But the benefit of the case managers and the recovery coaching is that that's boots on the ground to actually implement whatever the treatment plans are and the goals are that are developed with the therapist.
So how do you assist families and individuals during moments of mental health crisis?
Sure. So the first thing we do is we assess, right? So I had a old mentor that used to say all problems can be solved with good assessment, right? And so the first thing is we assess the situation, like what's needed. For example, we get a lot of calls where people are having a psychotic episode. They're unable to take care of themselves. They're not taking medication. So in a situation like that, it likely requires an initial hospitalization, which we can initiate, and then we'll coordinate care with the hospital that we have a lot of relationships with. Um, so we'll step right into the crisis. That's the easiest way to put it. And if it's a substance use disorder intervention, we want to again assess, see what the needs are. Part of one of the honestly, beyond the actual intervention, one of the most important things is finding appropriate placement, right? So where should this person get care? I think families, understandably so, are focused on like, okay, what's going to happen during the crisis intervention, which totally makes sense, but that is hopefully going to be successful. And most of the time it is, if the family is really committed. But we really need to focus on, well, what goes afterwards, right? What's the most appropriate treatment placement? And that's what we assist with
Mm.
too.
So that ties into my next question. What are some common challenges you face in coordinating care across different providers?
So I think, and any family or client that's been through this before, and probably a lot of providers will acknowledge that the biggest issue I see is that when there's multiple people involved, is that no one's talking to each other. So, you have a psychiatrist, therapist, recovery coach, outpatient program, group therapy, all these different service providers, and there's no communication hub because they work at different agencies. If it's all within the same agency, that's one thing. But even within the same agency, sometimes there's like significant communication problems. So really what I see as far as coordinating care, the biggest issue is that people just aren't talking to each other. So one of the things we do with the case management is we end up being kind of like a communication hub for that client's care. And we, have a group email thread, or we have conference calls, and just kind of keep everybody in contact so that we're working towards the same goals.
So clients have different goals, and I'm wondering how are you able to handle situations where clients are even resistant to help?
Sure. So there's a couple different avenues we can take there. So it's the expectation on my end, and most of the time when I get contacted, is the clients are resistant to help. Right. That's to be expected. And a more extreme version of that is people have with severe mental illness have what's called anosognosia, which loosely translates to denial of disorder. So they don't know that they're sick. Right. So of course they're resistant. And often we find that there's certain things that the families have adapted to just to survive that are actually not helpful to the person getting care, right? And so often to help people motivate, we can use leverage, right? And then there's also the emotional component where a lot of times families are just like they're scared to have the conversation. The identified client doesn't know what the impact is that they're having. So it's the emotional leverage, actual leverage, and then beyond that is motivational interviewing, right? So motivational interviewing acknowledges the fact that there are different stages of change that people are in. Could be pre-contemplation, contemplation, preparation, action, and maintenance, right? Those are the stages of change. And so if we know that somebody is in pre-contemplation or contemplation, you want to use like motivational interviewing to try and resolve any ambivalence they have towards making the change. Most often, people have some recognition that things aren't going well. They're just not sure what they're willing to do. And so, part of the process is trying to motivate them towards making that positive change.
Perfect. So, are there any plans to bring AI into your operations, like, for example, to streamline scheduling or manage case data?
Sure, yeah. So definitely, there definitely is. And I think that there's going to be a huge advantage to AI and mental health care, really healthcare in general, to free up clinician time with documentation, right? So, documentation, it's the stress of all clinicians that I know in terms of getting your notes in on time. And so there are great AI tools that we've been examining to try and implement to assist us with documentation. And then absolutely. Scheduling and those types of things. I think there's huge advantage to it.
What role do you see AI in playing in supporting rather than replacing the human aspect of your services?
Yeah, great question. And, this has been debated a lot in our field. You know, I am, I could be wrong. I know that there's been some studies that they've done with AI chatbots, not just text chatbots, but actual you know, AI that look like people, right? Doing therapy sessions with people, and then they found that some studies have found that it's equally as effective and sometimes more effective. I struggle to believe, and maybe this is blissful ignorance, I struggle to believe that AI will be able to replace the human connection of it. I mean, the healing process for so many people in therapy and other mental health care is just that human connection and that validation, that relationship built. So I find it hard to believe that AI will replace that in its entirety. With that being said, if there is some AI tools, if there are some AI tools rather, that can support people through mental health struggles, I mean, I think that's great, right? I mean, to me, it's about accessibility. So if it can help, and again, at the risk of repeating myself, I just struggle to believe that it'll fully replace that need for human connection.
Mm. So, what metrics do you look at to measure your success with that work?
Sure. So, I mean, there's like the easy metrics, which are, in terms of like substance use disorder, certainly, continuous sobriety. But beyond that, what we look for are what are called like life satisfaction surveys, right? So typically, people come in and they may be, having difficulties with their family relationships, their significant others, they're unemployed, they don't have purpose and meaning, they don't have a lot of life satisfaction. So there are several like evidence-based tools that we use to measure life satisfaction. And then there's also just kind of objectively looking at it and saying like, okay, prior to entering into treatment, like, was this person employed? Did they have a support system? Were they close with their family? Were they dating? Right? Like, do they have any type of meaningful career? So we want to look at that overall, like life improvement. And I think the important thing about that, though, in terms of outcomes, is to recognize that you know, everyone loves the story of somebody that enters into recovery, whether it's from mental health or addiction, and it's this totally linear process. And people are just, on the up and up, and, but that's not always how it happens, and most often it's not. And I think we have to shift a little bit how we view that. I think often, if somebody has a setback, it's viewed as catastrophic, but I really think it's just a normal part of the process.
And here's a deep one. What advice would you give families seeking help for loved ones in a crisis?
Yeah, no, I mean, it's a deep one, but it's so important. So I think what's hard is that depending on the crisis in the situation, there's the pressure to act now, right? Just do something, whatever it is, and hope it works out. I think there are certainly cases when that's warranted. If it's like an acute crisis, you need to contact law enforcement or something like that. You need to make really quick decisions. So I'm not discounting that, but as much as is feasible, depending on the circumstance, slow it down. right? Slow it down. Don't go, don't click the first treatment facility you find on Google just because they happen to have the best SEO or Google ranking, right? Uh, you know, if you already have involvement of a mental health professional, like an outpatient therapist, consult with them about what, may be the best option. And finding independent consultants and people that can be objective and navigate, because there's some characters, as you mentioned, in the addiction and mental health space. And I think many people are well meaning, but the reality is if you call any treatment center, their job on the other end of that phone is to get you into the facility, and even if it may not be the best fit. So slow down, really think about what's the best fit, what's the best program, and get some outside consultation if you can.
Yeah. Okay. And finally, what's next for full life comprehensive care? What are you aiming to build in the future?
Well, so it's and this is going to sound like a not so humble brag. I really didn't like when we first founded Full Life. I didn't think it was going to go this well, right? Not because I wasn't confident in what we were doing, but I knew there was a gap. I just wasn't sure if other people would feel the same way. And so what I found is that time after time, the feedback I get from families is we had no idea that an organization like yours existed. We wish we had found it years ago. And so the hope is to slowly and intentionally open up different offices in different locations that can benefit.
Well, thank you, John. That brings a close to our show, our episode here with Design to Thrive. That was John from Full Life Comprehensive Care. Thank you, John.
Thanks for having me, Doc. Appreciate it.